Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. So let's start, before we get into drugs, let's talk about, kidney cancer is a really interesting biologic disease. It's very diverse. I think it's probably one of the most diverse solid tumors, from patients who have, unfortunately, very rapidly progressive disease to this exceedingly indolent disease that we all see in our clinic. So Moshe, I'm gonna ask you, observation has become, I think, a relative standard in this disease. We did some work together in Cleveland on this, and others have looked at it. Who are you observing in clinic? What percent do you think it is? Like, what are the characteristics of those patients?
It's a great question. I think it's difficult to define the precise specific criteria that I use, but I would say it's about 10 to 15% of patients with metastatic disease. Most of these patients have had a nephrectomy and now have slowly growing pulmonary nodules or a couple of lymph nodes that are enlarging. So I look at a couple of features. I look at what's the rate of growth of the current lesions. Are there new lesions, or is there just growth in the current lesions? And then I use the IMDC criteria and how many sites of disease there are. So for a patient who has 0 to 1 IMDC criteria, or a patient has a small amount of disease that's limited to 1 or 2 organs, and it's not rapidly progressing, those are patients that I consider for observation.
And you're doing scans every 3 months in those patients?
Yeah, it's about every 3 to 4 months for the first couple of years, and then it really depends on the pace of their disease.
Yeah. Anything to add mind? Do you observe patients?
Yeah, absolutely, and lean heavily on your data as well related to observation. I think it's a wonderful data set to lean on. I think those principles you outlined regarding disease pattern, pace of growth, and so forth are all really critical. My frequency of scans is very similar.
Yeah. And Shuchi, how about you?
Completely agree. I think the biggest factor, as Dr. Ornstein mentioned, is the timing from nephrectomy. If it's been a while since they had a nephrectomy and now they're presenting after maybe 6-7 years with 1 or 2 lung nodules, I'll be comfortable observing those patients too.
Yeah, I think my practice is the same. I think the biggest question, patients love being observed. Mm-hmm. When we did that study, I think our IRB said, wait a minute, are you sure patients with cancer won't want to be treated? I'm not sure I've ever had a patient say, no, doc, I really want those drugs, right? They're like, oh, thank God I don't need therapy. Yeah. Yeah. I think the trigger to treat is tougher. When I'm talking to patients, it's sort of like, when you see it sort of thing. It's that accumulating disease, maybe a new site. I don't know if I've ever had a patient develop symptoms on observation. I think that's probably a little too late. Monty, talk about, I don't know if you're using SBRT in your practice. So we're kind of talking about the spectrum from indolent, low volume disease, oligometastatic, whatever you want to use. Are you doing SBRT to stave off systemic therapy in patients?
Absolutely, and it actually dovetails nicely on our conversation around observation, because from my dialogues with my radiation oncology colleagues, they have this sort of soft threshold of around 3 centimeters or so where SBRT tends to be most effective. So if I see lesions approaching that size, for instance, I might start having that conversation with the patient around SBRT in that setting.
Do you have, is there a limit? So 1 lesion, 2, 3, what if it's 5? You know what I mean? That's what I struggle with is over application of that, because I think there's a tendency among radiation oncologists to do it, and that's fine, but I'm worried about just radiating a bunch of asymptomatic lung lesions. I'm not sure is helping people. So what's your personal?
Absolutely, and it's so hard to be dogmatic about this. You probably said it best when you said, when you know it, you see it, you know what you can and can't treat with definitive local therapies. But I tend to use 5 as sort of a soft cutoff. I've seen 5 lesions as something that's applied in the radiation oncology literature. So if I see, for instance, a patient with 10, 12 lesions, at that point in time, unless it's really only 1 or 2 that are truly oligoprogressive, I probably wouldn't put radiotherapy on the table or other local definitive therapies.
Anybody else different?
I mean, I think it tells you something about the biology of the disease. If you're dealing with 3 to 5 lesions that are growing, so you can still potentially consider that patient as a lower risk disease with a more favorable biology that you could potentially delay systemic therapy by doing SBRT. But if suddenly there's 5 lesions and now you have another 5 lesions 4 or 5 months later, that patient probably needs systemic therapy. So it's selecting that patient where they're still within the favorable biology, they have a couple of sites growing, and that's where you'll administer the SBRT.
I think the biggest rationale is to delay the start of systemic therapy. Because when I'm intervening on a patient, I always ask myself, am I making this patient feel better or live longer? And again, SBRT to asymptomatic lung nodules are doing neither, I think. So I justify it by saying, well, if we could stave off therapy for a year, then that's probably a pretty good thing. I don't know.
Yeah, that's
differently.
no, that's exactly my strategy too, and that's exactly how I present this discussion to the patients too. If you tell them, I'm going to send you to a radiation oncologist, and that's going to probably buy us another 14, 15 months off systemic therapy, they usually go with the flow because, like you said, nobody wants to be on systemic therapy if not required.
Yeah, agreed.
So definitely.
Is anybody we talk about lung nodules, which is most common. Is anybody doing focal therapy too? You have 2 liver mets and doing cryo or other organs?
Absolutely. Yeah, I found that to be a very reasonable practice. Again, in the context of oligoprogressive disease, we can debate the definitions and so forth. But I really do think that this approach is something that applies irrespective of tumor site, across the vast majority of tumor sites.
Yeah, I think I get nervous with other organs because liver mets are usually not as indolent, but I agree with you.
And that's always the question. It's not necessarily the SBRT to the disease, it's what does the site of metastasis or the rate of growth tell you about the underlying biology? Because if you're going to do all this SBRT and 3 months later, you need to start systemic therapy anyhow,
You probably
should have just started.
Yeah. And we've all been there, right? Where you thought it was indolent, and then all of a sudden that next scan, it's not so indolent, and you probably didn't do the patient a favor, but I get the approach.